Hi everyone, my name is Nikhil Chaudhry and I'm a rising sophomore at Duke majoring in biology and global health. This summer with my mentors Andrew Flynn and Andrea Toomey, I worked on a policy brief discussing health policy recommendations to mitigate COVID-19 systemic barriers experienced by Black and Latinx communities. Black and Latinx communities have experienced an increased risk of exposure to COVID due to inequities in testing and vaccine access. In graph 1 on the left, we display monthly COVID tests done by Duke's health system per 1,000 residents of Durham County by race and ethnicity. Non-Hispanic white populations were being tested at rates much higher than non-Hispanic Black and Hispanic communities. In graph 2, the proportion of the white population receiving at least one dose of the vaccine is significantly higher than that of Black and Latinx communities in North Carolina. However, increases in vaccination rates began for the Black and Latinx communities at the beginning of March, corresponding to the start of community-based vaccination sites and organizations becoming involved. To illustrate the policy barriers and equity gaps that result in these inequities, we organized our research into 4 categories. First, the collection and reporting of race and ethnicity data is needed to identify communities that need additional resources. We saw that demographic data is not available for all COVID-19 tests given in North Carolina. The second category is using race and ethnicity data to identify needed resources. In Durham, testing and vaccine sites were located in health clinics in predominantly white neighborhoods early on in the pandemic. Also, age-related eligibility requirements did not consider trends of lower life expectancy among marginalized communities. The third category is increasing access and implementation strategies that remove systemic barriers. We noticed many barriers, including a lack of health insurance, government ID, or proof of residency that prevented Black and Latinx individuals from accessing testing and vaccines. Many workers in minoritized communities are not granted paid sick leave, further limiting access. Finally, the fourth category is engaging community partners for access, confidence, and trust building. Community organizations have historically been excluded from conversations surrounding health policy. It is important to partner with trusted community leaders to build connections and provide accurate COVID information to minoritized communities. Based on this work, we investigated 2 multi-sector community-based partnerships that address the needs of the Black and Latinx communities. Lat19 meets with the NCDHHS to advise on data collection and resources in Spanish. Lat19 partners with organizations to set up community-based testing and vaccine sites and provides connections for COVID-19 non-medical resources. The group also conducts research and policy analyses of equity gaps. Lat19 holds weekly meetings for the Latinx community, where guest speakers address fears and provide information. ACT Plus used available data to establish community-based testing and vaccine sites in Black neighborhoods of Durham in partnership with faith and community-based organizations. The group holds weekly meetings where stakeholders share information and community members voice concerns. ACT Plus forms partnerships with community leaders to connect people to COVID-19 information and other health services. Next, we analyzed major policy actions from the state government and assess the lessons learned. In Table 1, we list some of the key actions from the state government. In June 2020, the governor released Executive Order 143, initiating a health equity task force. To further this mission, the state government founded the Community Testing in High Priority and Marginalized Populations, or CHAMP initiative, setting up 300 free pop-up testing sites in underserved communities. CHAMP demonstrated the need for community-based testing, but data still showed equity gaps. In March 2021, NC added race and ethnicity data to its public vaccine data dashboard. However, the data for vaccines is displayed by county, so data is needed by zip code to specialize interventions. Later that month, the Healthier Together Coalition was formed, partnering with community organizations to distribute vaccines equitably. Finally, in May of 2021, a social vulnerability index map by Census Tract was released for COVID vaccines, but maps are still needed for testing and other health services. Based on our analysis of policy barriers and the lessons learned, we recommend the establishment of a coordinated mobile health clinic program. This initiative is organized into 3 recommendations. First, work is needed to the reform of payment models to fund mobile COVID-19 testing and vaccine clinics. Second, employees at these mobile clinics must be expanded, including community health workers, bilingual, and bicultural personnel. Finally, we recommend partnering with community-based organizations to provide non-medical COVID-19 resources. In the future, work is needed to collect and report race and ethnicity data for COVID-19 and other health conditions. Using the Social Vulnerability Index and race and ethnicity data, resources and health services should be allocated to the communities with the most need. Engaging state leadership and community leaders to address other systemic barriers to access is important to advance health equity. We must continue to partner with community organizations and elevate community voices when developing policy recommendations. With these recommendations in mind, we are hopeful that we can effectively mitigate the systemic barriers experienced among Black and Latinx communities when seeking access to COVID-19 testing and vaccinations. These initiatives will help ensure health equity in the future and lead the way for a more accessible and equitable healthcare system. Thank you.